Assalamu alaikum. I think we better start if you allow us. I would like to start by thanking Bayer for their support to our society and for this symposium. Our speaker for today is Professor Ricardo Capato. He's well known in the field of cardiology worldwide. He graduated from the University of Ferrara in Italy, and he specialized in cardiology there. He's currently Professor of Electrophysiology and Director of the Center of Clinical Arrhythmias and Electrophysiology in Milan, Italy. Professor Capato is the President of the European Cardiac Arrhythmia Society and a Fellow of the European Society of Cardiology and the Heart Rhythm Society. He's a member of so many societies, and he's the editor of so many clinical studies and journals. Professor Capato is an inventor of, and he holds the patency for human subcutaneous implantable defibrillator. He will be talking about stroke prevention and atrial fibrillation. Professor Capato. Sorry for the delay, it was against our will.
This is very kind of you. Good afternoon, ladies and gentlemen. It's
Very sorry for the delay.
To be here today and to have the privilege to speak in front of you about this very challenging topic. I will first cover on the epidemiology of stroke in patients with atrial fibrillation. Just some reminders. Stroke is the leading complication of atrial fibrillation, and patients don't know about it because the reason why they come is because they feel palpitation and they want us to fix the problem. They have no notion about the risk of stroke. We should have it. It is associated, atrial fibrillation, with a 5-fold higher stroke risk overall, which turns down to double the risk in the general population when adjusted for other risk factors. Without treatment, the annual risk of stroke of patients with atrial fibrillation is 5%, which means in 10 years, about half of the patients with atrial fibrillation will have developed a stroke. Atrial fibrillation is responsible for nearly 1/3 of all strokes, and atrial fibrillation is the leading cause of embolic strokes. Stroke is associated with a very heavy burden of morbidity and mortality. Quality of life is significantly impaired in patients who survive stroke, and most patients with stroke do not survive. It is usually more severe in patients with atrial fibrillation than in patients without atrial fibrillation. And compared with other strokes, those with patients with atrial fibrillation are more likely to have cortical deficit, specifically evolving into aphasia, have more severe limb weakness, more diminished alertness, and be bedridden on admission. The mortality rate for patients with stroke and atrial fibrillation is double as high as in people with stroke without atrial fibrillation. So atrial fibrillation is not only causing stroke at a very high risk, at a very high incidence, but if stroke happens, it is much more severe. Age plays a role. Age is never, it's good to become old, but it has its inconvenience. And atrial fibrillation is one of these inconveniences, and age-related stroke in atrial fibrillation patient is another inconvenience. It doesn't make any difference. We intuitively believe that if we are asymptomatic, or if we have paroxysmal atrial fibrillation rather than persistent atrial fibrillation, we are more protected by stroke because the intensity of atrial fibrillation is in some way less significant than in patients with persistent or symptomatic atrial fibrillation. This is not true. Asymptomatic atrial fibrillation and intermittent atrial fibrillation carry the same stroke risk exposure as symptomatic atrial fibrillation and persistent atrial fibrillation. So if a patient has atrial fibrillation, we should be alerted about his or her own risk of atrial fibrillation, stroke, unrelated to symptoms. Whenever a patient comes to our attention with atrial fibrillation, we have the privilege of being able to release him from our office with a clear picture of his individual stroke risk assessment. Because we know that if the patient had a previous stroke or transient ischemic attack, if he had a history of diabetes, hypertension, heart failure, or if his age is above 65 years, then he has a higher risk of stroke. And if we put these risk factors together, we cumulatively increase the risk exposure to stroke or death in patients with atrial fibrillation. You may appreciate the evolving value of the cumulative risk of stroke or death when with normal systolic blood pressure, age between 60 and 70 is considered, but then if we add increasing blood pressure, diabetes, smoking, prior MI, and signs of left ventricular hypertrophy on the electrocardiogram, we come up with an aggregate risk exposure which increases progressively. So each risk factor contributes to increase the risk of our patient. And if we simply take a careful past history of our patient and we perform an accurate physical and instrumental examination, we may be able at the end of it to come up with a number of relevant indicators of the potential risk of our individual patient to stroke. And we now know how to better protect them. Also, the presence of a risk factor is not only a yes or no phenomenon, but it is a progressive phenomenon. It is, I would say, a very delicate balance between normal and abnormal conditions, so that if patients have a normal LV function and have atrial fibrillation, their stroke risk exposure is much lower than if they have moderate severe left ventricular dysfunction. But there is an intermediate level of risk depending on whether the patient is on mild ventricular dysfunction or not. And also the overall risk can be calculated as low, moderate, or high depending on which risk factor and the number of risk factors. But there are some risk factors that are particularly heavy for our patients, like the presence of prior stroke or TIA, transient ischemic attack. Now, SCORE assessment has been introduced in clinical practice, and I'm sure you're all aware of the chart to SCORE, which is the score that we can identify for every patient coming to our attention. And if the patient has just one single element of risk, then his future risk would be 2.8% per year, with a 95% confidence interval between 2 and 3.8 of any anticoagulation treatment. If he has 6, you will appreciate that the risk is at least 6 times as high as it was if he only had one risk factor. And what we know is the higher the risk factor, the more urgent our need to treat him to prevent future stroke-related atrial fibrillation. And then a recent score has been introduced, which is the CHATS-VASc score by the European Society of Cardiology, in which 3 new elements have been added on top of the previous element, which are age above 75, vascular disease, and being a female. Females have a larger risk of stroke, of AF-related stroke, simply because they be part of the female gender. And then in the same individual, we also have to calculate the Hasbled score. This is very important because patients presenting with these categories, hypertension, abnormal renal or liver function, stroke, bleeding, labile, INR control, elderly, above 65, and drug or alcohol-related diseases, they have an increased risk of bleeding. So if we give anticoagulation therapy, we are exposing our patients to an excess risk of bleeding. Atrial fibrillation is also associated with enormous costs. The total annual medical costs of atrial fibrillation in the United States is estimated at $6.6 billion. And costs increase as the number of episodes increase. So if we have the first episode of atrial fibrillation, we will have a cumulative amount of cost that is almost double after 1 to 2 episodes and almost triple after 3 or more episodes. And costs are not only related to hospital costs, but also to outpatient costs, evaluation, and drug costs. So, the better we can prevent, the less the cost for our healthcare system. Vitamin K antagonists, so specifically warfarin, has played a major role over the last 50 years to prevent stroke in our patient population. And previous studies comparing anticoagulation therapy with placebo have shown that being treated with anticoagulation therapy is associated with an aggregate 64% relative risk reduction in the incidence of AF-related stroke, which means if we treat 100% of our patients with atrial fibrillation by means of vitamin K antagonists, and let's say 3 of them are about to develop stroke next year, 2 will be prevented because of anticoagulation therapy. So it will only be 1 out of 100 instead of 3 out of 100 patients with atrial fibrillation. And this is a major contribution that we are giving to medicine. Now, if we consider the 62% risk reduction, 64 relative risk reduction in the incidence of stroke and systemic embolism by warfarin as compared to placebo, we have to consider that out of 100 patients that are eligible to be treated with vitamin K antagonists, only 64% according to the Medicare cohort and 67% according to the Euroheart survey are effectively treated, whereas only 55% are treated according to the atrial cohort, which is a much more representative observatory of daily clinical practice. Which means every second patient that is eligible to treatment with vitamin K antagonists in order to protect him from stroke, we deny treatment. And this should not happen. And even most relevant, those patients who are at highest risk, above 85 years of age, because their stroke risk exposure is the highest, are those who are least treated with oral anticoagulants. This is intuitive. We feel uncomfortable to deliver anticoagulation to patients who are very sick, who are poorly compliant, who may fall, who are exposed to a number of additional factors that may produce drug-related side effects. But if we deny anticoagulation treatment every second patient who is eligible, then we are reducing the theoretical impact that anticoagulation treatment has to preserve patients from stroke if they have atrial fibrillation. And we reduce from 64% the relative risk reduction to 32 or less due to underprescription of vitamin K antagonists. Now, the next thing, if we do treat a patient with vitamin K antagonists, we are contributing to an emergency hospitalization for adverse drug reaction for the majority of drug-related events. Of all hospital admission to emergency hospitalizations due to drug reactions, warfarin is by far the most responsible cause, accounting for about 33% of hospitalizations to emergency department related to adverse drug reaction. And if we consider the population that from emergency department is transferred to the hospital, we will have warfarin again contributing as the most prominent drug responsible for hospital admission together with insulin-related adverse event. There are other limitations of vitamin K antagonists that are the unpredictable response requiring continuous dose adjustment and blood sampling for estimate of INR values. There is a narrow therapeutic window, and we will come back on this. there is slow onset, offset of action. At least 3 to 5 days are required in order to warfarin to accomplish anticoagulation regimens. There are numerous food-drug interactions that make our patients' quality of life very bad because they like to eat and they can't eat some things that they really love because they are taking warfarin. And there are numerous drug-drug interactions that we have to be aware of. And sometimes we are obstacles in our genuine intention to deliver this therapy because we feel that the drug that patients are taking because of rheumatic arthritis, because of diabetes, because of coronary artery disease and so forth may interfere with Coumadin. Now the INR, which is, you know, is an international rational corrected value for estimating the power of anticoagulation, has a very limited range between 2 and 3. And if we are unable to keep patients within this range, we either expose them to a high risk of stroke, particularly if the patients are underpowered, or to an excess risk of intracranial bleed because there is too much anticoagulation power in their blood. And there are studies clearly showing that stroke in patients who are anticoagulated most often occurs when the INR is below the therapeutic range. So patients are taking the effort to have their blood sample be controlled, not to eat what they love, to have a lot of drug interaction, to have a significant change in their quality of life, and yet are not as much protected as they would merit because of their effort. Now, based on all this information that has been collected in the literature over the last few years, the guidelines have adapted accordingly. And if a patient comes to our attention because of atrial fibrillation, our priority is now not to treat them with anti-arrhythmic drugs any longer, but it's first to assess the thromboembolic risk. So even before we take care of everything else which has to deal with the reason why the patient came, we have to estimate the stroke risk in our patient. And we have to start anticoagulation regimens, and particularly VKA, aspirin or none, depending on the previous guidelines. And then we take care of rate and rhythm control, we give antiarrhythmic treatment, and we take care of symptoms. We clearly do it in the same circumstance, but our mental priority should go to stroke prevention, because we are really impacting our patients' future and their quality of life. And finally, we can also treat the underlying disease and provide upstream therapy. We all know that if we reduce blood pressure in a patient with atrial fibrillation, the number of subsequent episodes of atrial fibrillation will be reduced. According to the most recent guidelines, and in light of the recent introduction of novel oral anticoagulants, which is an alternative form of treatment to vitamin K antagonists, the ESC guidelines have adopted the use of novel oral anticoagulants as an alternative to vitamin K antagonists. But vitamin K antagonist remains a recommended therapy for the treatment of all types of atrial fibrillation, and particularly for the treatment of valvular and mechanical heart disease atrial fibrillation. The three recently introduced novel oral anticoagulants are rivaroxaban, dabigatran, and apixaban. They are direct inhibitors of specific factors of the coagulation cascade. You will remember that Coumadin, vitamin K antagonist, is inhibiting a number of factors, including the factor 10, the factor 7, the factor 5, and the factor 2A. So Coumadin goes everywhere, essentially. Whereas novel oral anticoagulants, they only either inhibit factor 10 activated or factor 2 activated, which is thrombin. Dabigatran specifically is an inhibitor of thrombin, and rivaroxaban, apixaban, and edoxaban are specific inhibitor of factor 10 activated. These drugs are similar but are also different, and this is why they can be selected according to a different patient presentation, and we will go into some details later on. But they are essentially sharing the same half-life between 9 and 17 hours. They have a similar molecular weight, they have a similar time to peak. They have different renal excretion rates, with the bigatron being the one most frequently excreted by the, most predominantly excreted by the kidney. All these drugs have been tested against vitamin K antagonists in prospective randomized trials to prevent stroke and systemic embolism in patients with non-valvular atrial fibrillation against vitamin K antagonists. And they have names of trial that identify each molecule for each trial. So Rely for the bigatron, Rocket AF for rivaroxaban, Aristotle for apixaban, and Engage AF for edoxaban. Let's briefly touch on the main outcome results of each of these trials. Rely was testing two different dosages of the bigatron, 110 twice daily and 150 twice daily, versus warfarin with an INR target between 2 and 3 in 18,000 patients, 6,000 patients per arm. The primary endpoint was time to first stroke or peripheral embolism. And the working hypothesis was to show that novel oral anticoagulants can be used as an alternative to vitamin K antagonists. So it was a non-inferiority hypothesis. According to the study outcome, both dosages, the bigatron 110 twice daily and the bigatron 150 twice daily, were as effective as warfarin. Indeed, the bigatron 150 was found to be superior to warfarin, with the relative risk reduction of the aggregate incidence of first stroke and peripheral embolism of 34%, on top of the 64% risk reduction that warfarin has already made on its own as compared to placebo. So it is an enormous advantage of novel oral anticoagulants. Rocket AF was testing one single dose of 20 milligrams rivaroxaban administered once daily, not twice as the bigatron before, as compared to warfarin in 14,000 patients. Only one dose was tested, 20 milligrams, and 7,000 patients were composing each of the group. Compared to Rely, Rocket AF was including patients who are more representative of the usual atrial fibrillation population, because they are sick, they have congestive heart failure, hypertension, age above 75, and or diabetes. And at least two of these parameters needed to be present at the time when the patient was enrolled, or the patient had to be a survivor of stroke or TIA, systemic embolism. And according to this working hypothesis, which was the same as in Rely, of non-inferiority, rivaroxaban not only was found to be non-inferior, but indeed was found to be superior to warfarin, with a 21% relative risk reduction in the aggregate incidence of stroke and non-central systemic embolism. Aristotle was the third trial testing apixaban, 5 milligram twice daily, as with the bigatron, twice daily, versus warfarin. Just one single dose, 18,000 patients, 9,000 in one arm and 1,000 in another arm. Same primary endpoint, same patient population as with Rely. And again, apixaban, the novel oral anticoagulants, not only was it non-inferior, but indeed was superior with a 21% relative risk reduction in the aggregate incidence of stroke or systemic embolism. So novel oral anticoagulants have some advantages that are undisputable, because they don't need any blood sampling any longer. You take it by mouth, and the anticoagulation control is guaranteed by the molecular, chemical, pharmacokinetics, and pharmacodynamic characteristic of the drugs. And you can forget about any control, and you can let the patient home, and you don't need any food to drug interaction. As a family of drugs, they have recently been investigating, according to a meta-analysis published by Ruff and co-workers in 2013, showing that being assigned to novel oral anticoagulants is associated with a 19% aggregate relative risk reduction in the cumulative incidence of stroke or systemic embolism. And please remember, this 19% reduction is mounted on top of the 64% risk reduction that vitamin K antagonists do already possess from their own. Most importantly, this benefit is not played at the expenses of an increased risk of bleeding. All incidences of major bleeding and intracranial bleeding and gastrointestinal bleeding observed in these trials did not exceed the incidence observed in warfarin. So there is something which is exclusively related to the anti-thrombotic effect of the molecules that is responsible for the outcome data. And most importantly, the incidence of intracranial bleeding is half the incidence of intracranial bleeding with vitamin K antagonists. So one of the complications that was probably making us most hesitant to prescribe vitamin K antagonists in our patient population, namely intracranial bleeding, is reduced by half using novel oral anticoagulants. Now finally, ROCKET-AF is a very special study, and this is why I want to spend a little bit of time on this. Was enrolling, as I told you, a sicker population as compared to RELY. So rivaroxaban was tested in a much more, I would say, hostile environment as was the case for the bigatron and apixaban. The mean age of the patient population was at 73 years, higher than the mean age in RELY, where the bigatron was tested, 71.5, and 1.5 years at this age for stroke-related, for AF-related stroke makes a major difference. In addition, 55% of the population in ROCKET-AF had survived a previous TIA or stroke as compared to 20% in RELY, accounting for a 3.5 ultimate mean CHADS-2 score in ROCKET-AF as compared to 2.1 in RELY. So when we want to compare the bigatron with rivaroxaban, just based on the indirect evidence we have from these trials, we are not allowed to do so because we are talking about two different patient populations. Now, what were the contributors to the reduced incidence of stroke? You remember rivaroxaban was associated with a 21% relative risk reduction in the aggregate incidence of stroke and peripheral embolism as compared to VKA in ROCKET-AF. The different components are actually summarized in this slide, in which all-cause stroke did not differ significantly between the two phases. It was hemorrhagic stroke that resulted significantly inferior in patients assigned to rivaroxaban as compared to patients assigned to warfarin. And hemorrhagic stroke, as you probably all know, represents a complicated evolution of an ischemic stroke in which bleeding occurs as a result of reflow following acute ischemic lesions, like a reflow experience that we make in the heart after coronary artery occlusion. And and also very important, the incidence of non-central nervous system systemic embolism was by far inferior in patients assigned to rivaroxaban as compared to warfarin. Another very reassuring finding is the following. Remember, we were telling that there is no major bleeding in the population assigned to novel oral anticoagulants as compared to vitamin K antagonists, despite the benefit that we are providing in terms of antithrombotic efficacy. But there is even better information if we dissect out the different components of bleeding in ROCKET-AF. You may appreciate that the overall incidence of bleeding was more or less the same in rivaroxaban and warfarin. But the incidence of correctable bleeding, such as those causing hemoglobin drop above 2 grams per deciliter or requiring transfusion, was excessively observed in patients assigned to rivaroxaban, whereas the incidence of non-correctable bleeding, including critical organ bleeding and intracranial hemorrhage and fatal bleeding, was exceedingly observed in people assigned to warfarin. These curves here indicate which population is more protected depending on the specific type of bleeding that we are observing. So in summary, we have the same incidence of bleeding, but patients assigned to warfarin have a lower incidence of fatal or life-threatening or intracranial bleeding, which again is very reassuring. Now, a few final words for rivaroxaban in daily practice from the experience that has been developed after the publication of the first trial. Now, switching between anticoagulant regimens, you may find information in the patient card and in the physician's card whenever you're treating this molecule. But you need to be very accurate. We can't simply discontinue vitamin K antagonist and start rivaroxaban as if nothing occurred. You have to make sure that the INR value of patients taking vitamin K antagonist is below 3 before rivaroxaban is started. Otherwise, the combination of these two drugs is exposing our patient to an excess bleeding risk. If you want to switch from NOAC to vitamin K antagonist, we have to be very careful, because we know that if we start vitamin K antagonist and stop novel oral anticoagulants, it will take time before patients are protected. And on the other side, it will take very little time before the patients become unprotected from NOAC suspension and discontinuation. And the reason is their half-life, remember, is very short. So if we stop rivaroxaban today, our patient will have a normal coagulation condition tomorrow. Whereas if we start vitamin K antagonist today, it will take 5 days before the patient is fully anticoagulated. So combination of this therapy needs to be continued for a few days. And there are a number of other conditions that are all specifically reported in the patient and the physician's card. Now, ensuring compliance is a very important issue. Having a single dose administration like in rivaroxaban and edoxaban, as compared to requiring twice the same dose in patients with apixaban and dabigatran, may turn into a significant advantage for the first two molecules. Recent studies have proven that in patients taking cardiovascular medications, there is an up to 23% higher adherence taking once daily chronic cardiovascular medications versus twice daily intake, which may translate into a 23% dilution power of the anticoagulation properties of novel anticoagulants, which are required to be taken twice daily. Drug-drug interaction. Please appreciate there is only one single table, not very many tables like with vitamin K antagonists, highlighting the many drug-drug interactions that are possible with vitamin K antagonists. And if we concentrate on rivaroxaban, we see that atorvastatin, digoxin, verapamil, diltiazem, amiodarone, and dronedarone, which are the drugs that are not uncommonly used in association with rivaroxaban to treat atrial fibrillation, are all associated with no effect or with minor effects. Quinidine indeed is associated with a 50% higher intravascular dose of rivaroxaban, which may expose the patient to an excess bleeding risk. And the only drugs that are contraindicated are antimycotic drugs, which are very unusually used in this population. And finally, used in special conditions. Patient with renal impairment. If a patient has a renal clearance between 15 and 50 milliliters per minute, is reported or referred as to being affected by a mildly or severe renal dysfunction, respectively. In these conditions, to protect patients from stroke prevention, a dose of 15 milligram rivaroxaban once daily should be used instead of 20 milligrams. In patients with coronary artery disease, RELY has shown that dabigatran may be associated with an excess risk of myocardial infarction during follow-up. And probably this occurs because dabigatran is not as protective against myocardial infarction as vitamin K antagonists are. Now, a number of studies in which rivaroxaban has been tested to assess the risk of myocardial infarction in different patient populations, atrial fibrillation population, patients with venous thromboembolism risk, patients with previous acute coronary syndrome, and other conditions or combination of conditions that have all proven that being assigned to rivaroxaban is not associated with an excess risk of a myocardial infarction as compared to the used comparator in the given trials, including vitamin K antagonists. Clearly, this is not conclusive because the incidence of coronary artery disease during follow-up of these trials, thanks God, is not very high, but it is reassuring to observe that in patients who are randomized, who present with similar patient characteristic at entry, the incidence of MI in those populations assigned to rivaroxaban is not exceeding the incidence of MI in the comparative population. And the very last slide of my presentation indicates the breadth of indication of rivaroxaban. Rivaroxaban has been tested or is being tested in a number of variable clinical conditions, including stroke prevention in atrial fibrillation, prevention of deep venous thrombosis or pulmonary embolism in patients with venous thromboembolism conditions, acute coronary syndrome, a combination of atrial fibrillation and acute coronary syndrome, specific clinical conditions such as cardioversion, catheter ablation, clot dissolvement in left atrial appendage or left atrium, and peripheral artery disease and congestive heart failure. This breadth of indication indicates to me two different considerations. Number one, the drug is very flexible and its antithrombotic power is exerted throughout the entire body in different clinical challenges. And number two, the manufacturers that have studied so extensively this drug are very confident about the investments associated with the demonstration that these trials require whenever novel oral anticoagulants are tested against the best standard of care. So to conclude, Mr. Chairman, ladies and gentlemen, novel oral anticoagulants offer a wide spectrum of opportunities, providing a valuable alternative to vitamin K antagonists in patients with non-valvular atrial fibrillation. Overall, these novel oral anticoagulants appear superior to reduce the aggregate risk of stroke and peripheral embolism. Such effect is not associated with an excess risk of bleeding. Selection of which novel oral anticoagulants should be made is based on an individual case and not on indirect comparisons of results from different randomized control trials. And among novel oral anticoagulants, rivaroxaban has shown to be an effective drug in a wide variety of clinical conditions, including coronary artery disease, venous thromboembolism, stroke prevention in atrial fibrillation, a various combination of these diseases, and specific situations such as cardioversion, catheter ablation, and stent implant. Rivaroxaban also provides unique administration opportunity, once daily dosage, and easy of adaptation to special situations at risk, including renal impairment and high-risk coronary artery disease patients. Thank you very much for your attention.
Thank you very much, Professor Capato, for this elegant presentation, and the floor is open for comments and questions.
There are no experimental information about the risk of teratogenicity, which is reassuring but is not sufficient. Using a very conservative approach, pregnancy was considered an exclusion criteria in all trials that have investigated these drugs at the very early stage of development. I think with time there will be room, now that the drugs are implemented in daily practice and are so widely distributed worldwide, to probably investigate this very specific patient population in the future. Until then, I would discourage the use of novel oral anticoagulants during pregnancy, which means if a patient is on novel oral anticoagulants and becomes pregnant, I would rather switch back to the well-known old good vitamin K antagonist and follow the patient under this therapy.
Yes, please.
Thank you very much for this nice lecture. My question is regarding dabigatran. In elderly patients with pulmonary embolism, when we switch off from low molecular weight heparin to dabigatran, the dose 150 should be used, or possible to adjust to 110 like in patients with non-valvular AF.
You're talking from catheter prevention in patients who survived the previous pulmonary embolism event, right?
Yeah, exactly. Patients on pulmonary embolism, acute pulmonary embolism, starting with low molecular weight heparin, and then we want to switch off to dabigatran instead of warfarin.
Well, evidence shows that dabigatran is effective to prevent, is a valuable alternative to the current treatment, which includes vitamin K antagonists during the first 3, 6, or 12 months. So this can be used as an alternative treatment, and the recommended dosage is 150. But if you have an elderly patient or a so-called fragile patient with renal impairment or with low weight, then using 110 milligrams is available. And as a matter of fact, I know that using the lowest dose is a regular attitude in whatever indication concerning dabigatran. Even much stronger patients, you know, the young patient, the heavy patients, physicians feel comfortable to start with 110. I don't know why this is the case, because indeed we know that at least for stroke prevention of atrial fibrillation, using 150 is associated with the stroke risk reduction. But I think it's very intuitive that when we start with a new therapy, we feel more comfortable to stay on the safe side, use a low dose, and the more we become comfortable, the more we may switch then or move to a higher level. But to answer your question, 110 is adequate under the circumstances.
Thank you for new, excellent scientific data. And my question is cardiologist. Currently, according to European Society of Cardiology guidelines, rivaroxaban advised for patients for stroke prevention and atrial fibrillation. But what about stent implantation and patient planning for cardioversion? According to current guidelines, in confirmed, it's legal to use and replace previous drug with rivaroxaban with such category of patient.
There is a lot of food here, huh? So,
stents and cardioversion, rivaroxaban.
Yeah, a lot of food here. Okay, if you have a new therapy, atrial fibrillation of recent onset, no previous antithrombotic therapy, the ESC guidelines suggest that novel oral anticoagulants can even be considered as a priority in comparison to vitamin K antagonists. If you are already on vitamin K antagonists and you are well protected, there are no recommendations, and I would discourage to switch to novel oral anticoagulants. If you have a situation like cardioversion, we have sub-studies from each of these 3 trials that I've presented you, in which an aggregate of 2,200 patients underwent cardioversion during the follow-up. And the sub-studies show that patients who underwent cardioversion after assignment to novel oral anticoagulants showed a similar incidence of outcome, efficacy, and safety endpoints as in the vitamin K antagonist group, suggesting but not proving that if you already are on novel oral anticoagulants and you need cardioversion, you can safely be left on novel oral anticoagulants, have your cardioversion be performed, and be continued on novel oral anticoagulants. But if you are not on novel oral anticoagulants, we don't know whether you can start novel oral anticoagulants before cardioversion, and then you can continue on novel oral anticoagulants. There is a study, though, called EXPERT, in which rivaroxaban is going to be tested versus vitamin K antagonists to test in patients who are not on rivaroxaban whether rivaroxaban is as protective as vitamin K antagonists, standards of care, in patients undergoing cardioversion. These data will be presented at the European Society of Cardiology. So we will have an answer very soon also for this very special patient population. Now for coronary artery disease, we have 2 conditions. Condition number 1, you don't have atrial fibrillation. There is a study called ATLAS, ACS, in which rivaroxaban has been tested 2.5 milligrams twice daily. So a very different approach on top of dual antiplatelet therapy as compared to triple anticoagulation therapy as before in patients with acute coronary syndrome, showing that the incidence the cumulative incidence of cardiovascular events occurring during the 12 months after start of therapy was lower in the rivaroxaban group, and suggesting therefore that rivaroxaban can also be effective in this population. The second case is if you have atrial fibrillation and you develop a need for acute coronary syndrome, then clearly you are not on 2.5 twice daily, but you need a much higher dose of novel oral anticoagulants. And as of now, we don't have any answer. There is a study called Pioneer AF, which is prospectively testing 3 arms: rivaroxaban 20 milligrams with one single antiplatelet, rivaroxaban 15 milligrams and dual antiplatelet therapy, and current standards of therapy, which is vitamin K antagonist plus dual antiplatelet therapy. And this will test the variable influence that NOAC may have as an alternative to the current standard of therapy in this population. If you have a NOAC on board, and you have an acute coronary syndrome, and you have atrial fibrillation, you have 2 options. You switch back to vitamin K antagonists under the same assumption as I was alluding to before for the pregnancy condition. We don't have data about NOACs in this specific population. We'd rather stay on a safer side and use vitamin K antagonists. Or you can stay on NOAC, or you can stay on rivaroxaban in this specific situation. And in that case, you should use dual antiplatelet therapy for the shortest possible time, which means if you can select between a bare metal stent and a drug-eluting stent to hold the vessel open after dilatation, you may prefer bare metal stent because you are then enabled to discontinue Plavix after 3 months. And of novel antiplatelet therapy, Plavix is preferred because ticagrelor is much too potent, and we don't have data about the combination that triple therapy may determine in the presence of 2 novel drugs, ticagrelor and rivaroxaban or dabigatran or whatsoever.
One last short question and short answer, please.
Sorry for it long, but that was so.
Thank you. Excellent presentation. You mentioned at the beginning of your talk the risk factors, diabetes, hypertension, and then kidney, and then liver. Do you think, and now we're expecting that liver problem in the next few years will be the first problem in our country. Do you think that it is wise to give the drug for these patients, for liver problem? And thank you.
You know, liver problems represent a contraindication when we are talking about severe liver impairment. And the condition of severe liver impairment is very rare. We are talking about cirrhosis, we are talking about end-stage function of the liver. If we find subtle dysfunction of the liver, this is not an absolute contraindication. Clearly, we should determine the diagnosis. We should monitor those parameters that are indicative of the mild renal liver impairment, and make sure that either they are stable or they even improve towards a healthy status. Under these circumstances, NOACs can be used, but with care.
No, we're running short of time, so sorry. Again, Professor Cappato, thank you very much for this elegant presentation.